So the topic from the score standpoint was metastatic liver cancer, but I thought I'd include all the malignancies, or most common malignancies, and we'll go over the metastatic cancer with the score curriculum. That's on the website. So the three topic tumors that I'm covering would be the hepatocellular carcinoma, the metastatic colorectal cancer, and very briefly on the cholangiocarcinoma, because it's not on the score curriculum, but we'll just talk about it. So hepatocellular carcinoma, importantly, it's the most common primary liver malignancy, although, you know, for all comers, all cancers, it's the metastatic colorectal cancer that's the most common malignant lesion in the liver. But as far as the primary liver malignancy, hepatocellular carcinoma is the most common. Risk factors, as we talked about, we have cirrhosis, underlying hepatitis B, hepatitis C. Important thing, as we talked about in the first lecture, with hepatitis B, you may not necessarily see underlying cirrhosis, but see, you know, if somebody with underlying hepatitis B for a long time may just present with a hepatocellular carcinoma. Importantly, as we talked about previously, for fibrolamellar HCCs usually presents in young men, and there may be no underlying liver pathology. Workup, you know, if somebody, you gotta be suspicious, somebody with history of underlying cirrhosis or alcohol. So if they see a lesion that's seen incidentally on a scan, first of all, you know, you can start with AFP. That may or may not be high. Usually it'll be high, but again, the most important test would be the imaging, either CT or MRI, and then you have to do it with IV contrast. Important thing is it has homogeneous enhancement in the arterial phase, and there'll be a rapid wash out in the early portal venous phase, and that'll be characteristic. So we talked about you don't need a biopsy after this. Management, usually it's surgical, but there's several aspects to it. You could have transplant surgery, you can have surgical resection, you can do ablation, embolization, and chemotherapy. For transplantation, you know, the pros would be, some people would describe as the best option. It is associated with the best outcomes compared to resection, and one of the major advantages is it not only manages or treats the malignancy, but also essentially takes care of the underlying cirrhosis, which would be responsible for further recurrences in case of surgical resection. What are the disadvantages? You know, there is limited organ availability, so not everyone would be able to get a liver transplant, and of course the need for transplantation for immunosuppression after the transplant. So just as an aside, what's the most common malignancy associated with immunosuppression? Yeah. For liver transplant, important thing you need to know is a Milan criteria. And what it entails is either there's one lesion of hepatocellular carcinoma that measures less than 5 centimeters, or there could be up to 3 lesions with each measuring less than 3 centimeters. You know, if it falls outside of this criteria, patient will not, or if it's a metastatic disease outside of the liver, then patient would not be a candidate for liver transplant. For resection, so important thing is the underlying cirrhosis associated with, especially in setting of hep C, underlying cirrhosis will determine what kind of surgical resection patient may be a candidate for, because the important thing you have to consider would be post-op liver failure and also recurrence, as we talked about. The transplant, you know, you don't worry about recurrences because you don't have a cirrhotic liver anymore, but there will be recurrences in case of cirrhosis even after you resect the first malignancy. So for any major liver resection, important thing would be patient has to have a child A criteria, or a child A, we talked about the child's criteria, so only with patients with child A would be candidate for major liver resections. There shouldn't be any no portal hypertension. 5-year survival is about 30 to 60%, and even after resection there could be a 33% recurrence rate over 5 years. Prognostic factors after resection would be major vascular involvement, microvascular invasion, tumor number, and tumor size. These will determine again your recurrences and your survival rates. Important for margins from a standpoint, you at least want a 1 centimeter margin is what the goal is for hepatocellular carcinomas. Another thing to consider for resections is anatomic versus non-anatomic. Most books would say, you have to have an anatomic, but there have been several meta-analyses they've looked at, and they don't really say anatomic resection has any advantage over non-anatomic in terms of recurrence rates. One other thing you have to consider would be the future liver remnant. So for a normal liver, you have to have at least 20% future liver remnant. If patients had chemotherapy, especially in a setting where it's metastatic colorectal cancer you're treating, then you at least have to have 30% future liver remnant, and in setting cirrhosis, you want 40%.
Previous slide, so it has been asked in oral boards, how do you measure FLR?
So there are volumetric studies. You actually do CT scans and MRIs, and there are special computer programs that you can sort of merge the two, and they look at the blood supply that will the remainder of the liver will have, and based on that they determine the function of how much functional liver will be left. So that's how you determine the future liver remnant.
Would it be adequate to just say we would get a volumetric study?
Yeah, you can, but then as they say that any word you utter, it becomes like a tennis match. Then they go, what volumetric study? So you can either say,
evaluate future liver.
yeah, just say FLR. It's not a pass-fail question. It's like it's a flow. The flow is good, so then they can ask. But for the written exam, it can come as well. It's like what do you say? They'll go from there. You agree?
So briefly on ablation, so most textbooks tell you it's indicated for lesions less than 3 centimeters. If it's over than 3 centimeters, it's a contraindication. Most studies will tell you it has similar outcomes to resection. So, but if you can resect the lesion, that's probably still your best option. You shouldn't ablate, but ideally you use ablation as an adjunct to major resection. So if patient has, say, a lesion in the left lobe and the right lobe and needs a left hemihepatectomy, you do the resect the left lobe, and then for the right side you can then maybe ablate if it's a small lesion. Two different types of ablation, RFA versus microwave. Both cause coagulation necrosis. For RFA, you actually use electrical current that produces thermal cytotoxicity. Microwave is more electromagnetic energy converted to heat. Important thing is a heat sinking phenomenon. This is more sort of prominent with RFA, although it does happen with microwave. So if your tumor is near a major vessel that's greater than 3 millimeters in size, you worry about a heat sinking effect. So maybe that may be one scenario where you may not want to do ablation, because you may not be able to get complete coagulation necrosis of the tumor. And what the heat sinking effect, what it does is it removes the heat before complete tumor ablation, so you may not get complete ablation. As I said, it's more prominent with the RFA. Important thing is both of these, microwave and RFA, if you ablate tumors, they can present as abscesses. Contraindication to RFA, any tumor located less than 1 centimeter from the main biliary duct, and any coagulopathy would be contraindications to RFA. Briefly, other mechanisms is you can use TACE, chemoembolization, can be used if transplant, resection, or ablation is not possible. Some centers use it as a bridge for transplantation. Could be used as a temporizing measure while you're waiting for an organ for the patient. Used before ablation for, say, tumors 3 to 5 centimeters. We talked about you can only ablate tumors that are less than 3 centimeters. So you could employ the TACE. If the lesion is, say, 4 centimeters, that might shrink the size down to 3 or less, and then you can ablate. Response rates are up to 80%. But the drawback is the procedure needs to be repeated every 3 to 6 months if you don't get a definitive therapy. Say if the patient doesn't get a transplant or you don't ablate. Contraindication for TACE would be a total bilirubin greater than 3 centimeters, and portal vein thrombosis is one of the relative contraindications. So for metastatic hepatocellular carcinoma, surgical resection is contraindicated. So in that setting, sorafenib is actually shown to maybe improve survival in those patients. Metastatic colorectal cancer, important thing to remember is liver mets will be diagnosed in up to 15% of the patients who have colorectal cancer, either synchronous or metachronous. Workup would be, you get a CEA level, you'll have to get a PET CT to make sure, there's no other lesions, because these can also metastasize to the lung. And of course, if you haven't had a colonoscopy, especially in a metachronous setting, depending on how far removed you are from the primary tumor, you may need a repeat colonoscopy. So if patient presents with synchronous mets in a setting of colorectal cancer, several different approaches. You could use a neoadjuvant chemotherapy versus adjuvant chemotherapy, or you can have, so that's important, either you can go, again, both approaches are correct depending on where you train and where you are. Either you can, if you have somebody with synchronous metastases, most places would actually do a neoadjuvant chemotherapy, because one, it will tell you the response rate of the tumor, if it shrinks or not, and two, if it's an overly aggressive tumor, because it's presenting synchronous, they may even sort of, the metastatic lesion may even multiply on chemotherapy. So at that point, you patient may not, if it's an aggressive tumor that's metastasizing on chemotherapy, you may not need surgical resection. The other approach is, you can do surgical resection up front and then follow that up with adjuvant chemotherapy. And even the resection, there's several different approaches. So either you could tackle both the colon and the liver at the same time, or you could do the liver first and then do the colon, or vice versa, to do the colon and first and liver. Again, depending on where you train and what your preference is, you could do either. So resection, important thing is for hepatocellular carcinoma, if it's metastases is extrahepatic, there's no role for surgical resection. But in the setting of colorectal cancer, patient may have metastases in the lung, but a surgical resection of the liver is still indicated. And goal for resection, we talked about for hepatocellular carcinoma, at least a 1 centimeter margin is the goal. But for colorectal cancer, microscopically negative margin is what your goal is. For metachronous lesions now, patient had a colorectal cancer that had underwent resection, and say 3 years down the line develops a liver lesion that's consistent with metastatic colorectal cancer. One approach would be to do what we call a sandwich therapy. You can do 3 months of chemotherapy, follow that up with resection, and then 3 months of adjuvant chemotherapy. Most common regimen is FOLFOX or FOLFIRI, and Avastin is used in the setting of metastatic colorectal cancer. I don't know, sometimes they may ask you in your written boards, irinotecan is associated with steatohepatitis, while oxaliplatin can cause sinusoidal congestion. And that's the reason why you don't want to, if you're using neoadjuvant chemotherapy in setting of metachronous lesion, you don't want to do 6 months of therapy. Do 3 months because of the effect on the liver, because you got to end up resecting, and so you don't want liver failure after the resection. 50% 5-year survival rate after resection. This is an important question. This is prognostic factor I asked several times. So what are the prognostic factors in metastatic colorectal cancer? So disease-free interval between diagnosis of primary tumor and diagnosis of liver mets. So that's an important prognostic factor. So somebody who had colorectal cancer, had it resected, and then develops liver mets 6 months down the line, versus someone who develops it 3 years down the line, that's an important prognostic factor. Lymph node status of the primary tumor when you're resecting the colon cancer, whether the lymph nodes are positive or not, so that's a prognostic factor for metastatic colorectal cancer. Size of the largest hepatic tumor and extrahepatic disease. So these are important criteria you got to look for. Role of portal vein embolization. So, if you have bilobar disease both on the left and the right segment, and patients, they may need an extended right or extended left, That in that setting, you worry about not having adequate future liver remnant. Portal vein embolization is a good technique to employ. The most common way to do it is percutaneous transhepatic, and redirects the portal venous blood to future liver remnant, causing hypertrophy. So I just wanted to go over this was when I looked through the SCORE curriculum, the important things that we can go over. So given a patient with synchronous metastatic colorectal cancer, Chief Resident can identify those patients who can undergo resection of the primary metastatic tumor in a single operation, depending on location. So as we talked about, if it's synchronous lesion, it's your judgment call whether you can resect both the primary and the metastatic in one setting or not. If you feel not, you can either do colon first or liver first. Most centers will tell you liver first, but if patient presents with colon obstruction, then you would probably end up wanting to resect the colon first. Given a patient with large hepatic metastasis from colorectal origin involving the right lobe extending into segment 4, so essentially both the right and left are involved, Chief Resident can identify patients who have at least 25% future liver remnant, who are resection candidates, versus those who do not have enough remnant and should undergo right portal vein embolization. We talked about. So, given a patient with colorectal mets and significant tumor burden, Chief Resident should know the strategy of stage resection that takes advantage of the capacity of liver to regenerate. So again, if there are both right and left tumors, you have to do a staged operation. So given a patient presenting colorectal cancer, Chief Resident can acknowledge that he or she has a 50% chance of developing hepatic mets, so about a 50% chance of liver mets. This is also important. Given a patient with known history of colon cancer and a new hypoattenuating lesion on the CT scan of the liver, Chief Resident can diagnose hepatic mets based on characteristic imaging without need for biopsy confirmation. So that's important. You don't need a biopsy even for metacarous lesions. If somebody has a history of colon cancer in the past, now has a liver lesion that's characteristic, usually they appear hypoattenuating. They don't light up on arterial phase like hepatocellular carcinoma. If that's characteristic in patients with colorectal history, cancer history, then you don't need a biopsy. So you can proceed here with chemo or resection. Another important concept is, given a patient resected colon cancer 2 years ago and a new hyperattenuating solitary lesion that's 2 centimeters in segment 3 of the liver without evidence of extrahepatic disease, this patient can be evaluated for surgical resection. Compare that to this, where patient had multiple liver mets 8 months after colon cancer resection. Chief Resident can recognize this patient should be considered for neoadjuvant chemotherapy. As I talked about, this is an important prognostic factor because one was 2 years ago, one is 8 months, so that tells you it's more aggressive. Plus, this is a solitary lesion that's 2 centimeters, and these are multiple liver lesions. So tumor size as well as the number of tumors also prognostic. Given patient colorectal liver mets in whom multiple comorbidities preclude safe resection, Chief Resident can consider percutaneous ablation, as we talked about, as an alternative approach. Given a patient with resectable colorectal cancer, the Chief Resident can acknowledge an average 30-day mortality of 2% of such patients and overall 5-year survival of 25 to 48%. So about 50%, most places will tell you. So open-ended questions. 48-year-old patient, recent diagnosis of right colon cancer, has a 2 centimeter synchronous liver lesion in segment 3. How will you manage this patient? So as we talked about, most commonly metastatic to the liver. Understand the multi-phase of CT and PET scan are used to it. So as part of the workup, you'll get the liver protocol CAT scan. You may even get a PET scan to make sure it's not extrahepatic disease. And then possible treatment options and feasibility. So for synchronous, we talked about, would you consider neoadjuvant chemo first or go for surgical resection? For surgical resection, would you tackle both the liver and the colon together, or you could do it separate operations and then follow it up with adjuvant chemotherapy. So both approaches would be correct. Unless, of course, so what they tell you is, if there is, say, you have to do an LAR or an APR, you don't want to do a resection in that setting, even if it's a left lobe. You probably should, because it's a complicated approach. But if it's a right hemicolectomy you're doing and patient has a lesion in the left lobe that you can just resect, because left lobe is not as technically challenging resection, or say segment 2 or 3, you can fire a stapler, so maybe you can do that in the same setting. So 55-year-old woman with history of resected colorectal cancer 1 year ago is found to have multiple liver mets. What are the next steps in her management? So what would you do next?
PET scan. Want to make sure there's not additional metastatic disease with multiple liver lesions within a year.
Yeah.
They'd recommend neoadjuvant and then look for resection options.
PET scan related in identification. So important thing is you got to restage. So if you employ neoadjuvant chemotherapy, you got to restage, because what if the patient actually got progressed on chemotherapy? 75-year-old man with significant comorbidities found to have 1 centimeter hepatic lesion, suspicious for metastases. 5 years after his left hemicolectomy for large sessile tubulovilous adenoma. He's at high risk for surgery. What are your options? Yeah.
It's under 3 centimeters.
Yeah. Alternative treatment would be ablation, yes. Would be RFA, would be microwave. This is an important one though, might come handy in oral board settings. 55-year-old with 4 liver mets of colon region segments 2 and 3, responds to treatment chemotherapy and now has no evidence in CT or PET. What are the next steps?
You still proceed with resection because 8% will recur without resection.
Plus, it's important, they talk about complete radiologic response versus pathologic response. So just because somebody had a complete radiologic response, you don't see anything on the CAT scan, the PET scan, that doesn't mean that the tumor's still not there. Because I mean, there's those lesions that CT would probably pick up anything over 1 centimeter. What if it's 2 millimeters, 3 millimeters? It may not show up on PET or CT, but you still got resected. So, again, some people will tell you if it's a 2 centimeter lesion on the liver and you're actually going for neoadjuvant chemotherapy, put a marker there. Or stage them frequently. Maybe get a CAT scan after 1 month of chemotherapy to make sure that, if it's small enough, you want to get it before it completely disappears. So you know exactly where you're going to resect. Any questions? The important thing would be all the things that we talked about, the approaches and stuff, but the prognostic factors we talked about before, seen that come several times. So that's important.